Thank you for joining us to help choose home when care is needed. A podcast all about the values and benefits of receiving care in a place that you likely would feel the most comfortable in your own home. I'm your host, Marilee Orsini, and I have been involved in healthcare at home since 1981. Each episode, I'll be talking with a guest who will help us in our quest to educate about the healthcare at home and lots of information about that. So let's get started on today's episode. This is our first episode, and our guest today is Shiela McMackin. Sheila is a licensed clinical social worker, and she's been in home care for decades. She is most noted for being the founder of what is now the Home Care Association of America, and we're excited to have her today. And thank you for joining us today, Sheila. You have been involved in home care, I said, for decades, but when was your first home care experience?
Well, it was a little old lady who lived, actually it was fascinating. Our first client sort of dropped in our laps, and she she had lived in a community, a changing community, and she was the only person on, like for blacks, who was white, and her neighbors had all become black African Americans, and they were so protective of her. It was really a fascinating dynamic, and we took care of her 24 hours a day, 7 days a week. She had never had any children. Her husband had built the home that they lived in, and her family had actually, they were pioneers in one of our western suburbs. They had, she was German, I think they were German. They'd come over from Germany, and they were farmers. So, and she she was still driving her car, and she shouldn't have been. So that was a whole, we had to wean her off of the car, and she was quite a pistol, but it was a very interesting first experience. Learned a lot.
And that you said that you sort of fell into your lap. How does a person who needs care fall into your lap?
Well, now you have to remember this is, 30-odd years ago, and, there wasn't as much competition, and we were sort of new on the scene. And here in Chicago, there were a lot of our first referrals came from elder law attorneys, and that's exactly who made the referral. She and her husband had an attorney who he had become her guardian and he needed someone to manage everything, and that's exactly what we did. He was a really good guy and very invested in her care and very diligent, but he was, he had a family and ran a business. So we did all of the day-to-day management and took her to doctor appointments, had a whole full care plan, and he was very grateful and supportive.
So when you started, you said she fell into your lap and was an elder law attorney referral, but are we talking about after you started doing geriatric care management? Because you have a pretty rich history in geriatric care management as well.
Right. Well, I think he may have, to be honest, I don't remember. I think he may have called us as looking for a care manager. And then when we kind of unraveled and he told us that she was living alone and she needed care and she wanted to stay at home, that's when we said, because we had been working on a business plan because through our care management practice, we saw families and individuals at the time who really, this is back before assisted living was very, and even retirement communities were few and far between here in Chicago. So you either went to a nursing home or your family tried to struggle through figuring out how to care for you, or there were a handful of home care agencies. And we said, there's a real need here. And so it was one of those things where he called and wanted us to do one thing, and then we said, so let's pitch him this idea that we could run a home care agency. And he was very helpful and knowledgeable, and he also trusted us. And so that we basically learned, it's kind of like on-the-job, training.
And you say we. Are you talking about your partner in the business and also in life?
Yes, yes, that would be, yes, Dr. Stephen Fox. We had been care managers together. We had put that business together, and we were doing, essentially what care managers do now. We did assessments. We would write up care plans. Then we would help families find the resources, explain how they got paid for, or publicly funded programs. And as we were working with our families, we would get to this point where people would say, but how do we provide care? Should we keep her at home? Should we place them in a nursing home? And there were so few resources out there for home care at the time that we recognized right away that was an area that we wanted to expand into.
So it was a natural expansion because it was care that people needed.
Yes, exactly.
And this was, 30 years ago, perhaps?
Yes.
30 years ago. And so when you started your home care business, you started it basically out of a need. People needed you to come in and help them manage their lives and manage their care.
Correct.
So the whole idea of educating about choosing home care as an option, what do you say to people today when they come to you with a care need? Are there some upfront questions that help you know if someone should be choosing care at home?
One of the things I will tell you is that I've changed my view on the choices. And because, I used to say, you need home care, don't, retirement communities, assisted living, but what I've learned as I've gotten a little wiser is that I've actually seen people, and some of them have been our clients, and then they've made a transition to, we had a client for years, and the problem was that she was very physically active, and being at home alone with our caregiver, it just didn't work. We couldn't keep her active enough, and so she went to assisted living, and our nurse went out to see her to check in and see how the transition was. She was blown away. She was running this whole group of women. They were doing activities, and they spent their whole day together. And what it was is she really needed that group of stimulation. So, I don't know if I know right away how this is all going to work out, but and that's why I think that it really requires us to build relationships with our clients and their families so that we get to know them over time and really be able to get a sense of whether home is going to be the right option. And then we work really hard, to make sure that, we do everything we can to make it as possible for them. But there are some people for whom being in a group setting can really be much more, they do better.
Mm-hmm. When in those scenarios where that's happened, when you recognize that, do you work with them and guide them, or is it their choice? Do they recognize that they need the stimulation, or that they're ready to leave the place that they've called home?
Usually it's their decision or their family's decision. Often, to be honest, it's, now this situation worked out pretty well, and it wasn't rife with lots of problems. But when other people have moved on into a group setting, it's usually because they're not benefiting from what home offers. There's a lot of anxiety, or a lot of, they're not sleeping well, and so they're up and they're disruptive, and there are a lot of behavioral changes. And it just becomes too labor intensive to manage them at home, I guess. And, and sometimes it's a group decision, a mutual we'll talk to the families and say this isn't working out, and they say, yeah, we can see that, and then a decision will be made to take someone, and try assisted living, different levels of assisted living.
But when they do move from home into assisted living, that doesn't preclude that a home care agency might still have someone with them as a companion or to assist with some of the activities of daily living.
Oh, yeah, absolutely. I mean, we have plenty of clients who the caregivers follow them into the facility to, especially for the ones who've become very close, dependent, and people with memory impairment problems who have a hard time adjusting to new faces. So yeah, we will walk right in with them, and their home now is assisted living. It's not their condo or apartment or what have you, but it's still their home, and we're there to work with the staff and to work with the client to ease that transition.
You, throughout your career, have always been an advocate for the older person or for the person who needs care. Do you have any shining examples of your advocacy that has benefited some of the people for whom you've cared over the years?
We've learned over time that, especially in institutional settings like hospitals, one of the things I've learned about hospitals is that they're places where there's lots of goodwill, but they're institutions, and they're sort of set up for lots of problems to occur. There's always these breaks in communication that then impact the client. And I think that, that's where I've seen some of the work that we do to make sure that, we had a client, now that I'm thinking of it, we had a client who's at the end stage of her dementia, and we were taking care of her at home, and she went to the hospital, and the caregiver stayed with her, in the hospital by her bedside because she's very disoriented, and she needed to have a thickening agent put in her fluid. Mm-hmm. And so the caregiver called me and said, they're going to send her home with thicket. And I said, well, okay, I want you to make sure that you go to the nurse's station and ask them to send the the speech therapist or the dietitian to the room to show you how to do that. And now, and this doesn't exactly answer the question, but because I was testing out to see by being proactive, if we would get the right kind of response. Now, I know that our nurse would go to the client's home in like a couple of hours after they got there and would make sure that the caregiver had the right instructions. And most of our caregivers already knew how to do it because they'd used it before. But what I was thinking about was, when you're by yourself and you don't have anyone in the hospital to advocate for you, or if you're a family member and your plate is full with lots of things, what happens? And what ended up happening was that the nurse's station said, oh, that's a great idea. We'll send somebody up. Well, that 8 hours later, they were getting ready to leave, and of course no one came. And they were sent home with no instructions on how to use the thickening agent. Now, I know that I wasn't too worried about it because I knew we could handle it. But I was thinking about how rough that must be and I see that every single day of the week, families and older adults trying to navigate healthcare systems, and with nobody to advocate for you, it's pretty bad. It can be very bad.
So that's one of the things that I know that you all have done a lot. The other thing, since you brought up hospitals, all of the talk in the industry about preventing rehospitalizations, it seems to me that you all not only prevent rehospitalizations, that you work to prevent hospitalizations in the first place.
Correct.
Can you talk a little bit about that? Because you have a system that works amazingly.
Why, thank you. Yeah, no, what we recognized, we were all sitting around the table about 5 or 6 years ago, and really looking at all of the model projects and the research grants and all the work that was done around hospitals and discharge planning and readmission rates and et cetera. And we took a look at our own clients, and we realized that our clients didn't go to the hospital, or rarely. And we went, well, gee, that's great. I wonder why. We knew it anecdotally, and we saw it happening, but we had no clue why, other than, gee, we must give really good care, which was part of the answer. So we really dug deep and started taking a look at collecting data and using technology to collect data, and we created the Home Care Metrics program, which is available for all of our clients. We use a tablet in their home. It's a system of, we train our caregivers. Essentially what we do is we train them to identify changing conditions. And it's really based on some very simple concepts that there's been a lot of research done on that to show how effective, and they're called geriatric syndromes. And really everything stems from older adults. A lot of the hospitalizations stem from preventable events if you're paying attention. You know, bowel impactions or bowel habits, hydration, fluid intake, sleep hygiene, whether you're getting enough sleep. So there's like 5 or 6 things that our system really pays close attention to, and when there are changes, we immediately respond. And so every day we'll get our notes electronically, and there's a special way for the caregivers to identify change in condition. Like one of UTIs or urinary tract infections can be very significant in older adults, and they're often marked by behavioral changes. And so, sleepiness or delusions or just they're not feeling or sounding the way they did a couple days ago can be the first, clue that someone's got a UTI. And we've been able to make, by just tracking those kinds of little things, and, caregivers all across every, not just ours, but all caregivers have this innate ability, potentially, not to really sense the change that occurs in someone that they're caring for. So even from the sound of their voice, they can tell, yesterday they were doing better, and today there's a change. I don't know what's causing it, but I can feel it. So that kind of stuff can be translated into, our nurse gets the information and then acts on it. Call the family, call the physician, call the home health agency, and make, triage it, and then have them help us decide what we need to do to address the issue. We've seen some remarkable saves, like things that, aspiration, people start coughing, and we know that they've probably aspirated on something, and it's not necessarily a cold or the flu or whatever. So there's all these different little things, or somebody is, we're tracking we have this thing called the poop chart, and what we do is all of our caregivers use a chart that has like 5 or 6 different types of poops on it, and it's systematized. So everybody is either a 1 or a 2 or a 3 or 4. It's not, it's not individually interpreted through the caregiver. It's actually from looking at the chart and matching it up. And it's improved a lot of outcomes for our clients who, all of a sudden they're not drinking enough or they're not getting enough fiber, and we start noticing bowel disruption. And we can address that immediately and, save a trip to the emergency room, bowel impaction, other types of problems.
That seems incredibly simplistic in a world where I see lots of charts and thousands of codes for things. Is your capacity to be able to distill things into the basic terms because your model of care is paid for privately? Is that the difference?
I don't know. That's a really interesting question. Because people pay privately for our services, we don't have the constraints that you do if you're, publicly funded. But at the same time, there's some things that publicly funded organizations have access to that we as a single site provider don't have. But I wonder, I'd have to think about that. That's a really good question.
I just wondered that because I continue to follow the rules and the regulations and the changes and conditions of participation for the government-funded programs. And it certainly seems to me, I believe the latest ICD-10 has, 40,000 different options to choose from?
Holy moly.
And there's a pathway, a workflow that you have to do. So, but you are licensed in the state of Illinois, and you've been very active in the licensing and regulation of others in your industry. And that's been a passion of yours, wouldn't you say?
Oh, yeah, absolutely. I was just talking to somebody about it this morning. I had a meeting this morning, and I was kind of going over the history of the industry for my view of the history of the industry. And, I have my favorite saying that people laugh every time I say this, that if you don't have a seat at the table, you're going to be on the menu. And what I mean by that is that we knew, and it didn't take a rocket scientist to say or to know that this industry was going to expand, and it's not only expanded, it's like blown up, and there are just huge numbers of organizations out there, good, bad, and indifferent. And so it goes without saying that eventually regulation, governmental entities were going to see that and say, okay, now we have to do something. So it's better, in my mind, if the regulation that's going to come anyway really be influenced by the people that are going to have to live it day to day. So making sure that it's, because I don't think that good regulation is fine. Bad regulation is what causes the problems. And if you as an industry person have access and have influence over what that regulation, how it's going to be written, how it's going to be monitored, and building relationships. The other piece of it is that it's important to build relationships with the regulatory entities. They need to understand what your day-to-day issues are, and it really helps.
It's getting close to time for us to end our call. I could probably talk to you for hours, but but I had a thought in terms of your model of providing care, your passion for the industry, and the idea behind this is to help someone who might not understand that there is care available at home to make a more informed choice. So if you just had a blanket statement to give to someone about choosing a home care agency or choosing care at home, what would you say?
Well, I guess what I would say is the first step to ensuring a level of quality is to choose an agency that participates in the Home Care Association of America. And because the trade association that represents our industry has made huge efforts to professionalize and make more sophisticated or increase the sophistication of our industry. And so I think for consumers who are confused and don't know, that would be the first place to start.
Good. Very, very good. Well, Sheila McMackin, president of Wellspring Personal Care in Chicago, thank you so very much for your time today.
Thank you. It's been delightful.
Thank you so much for listening today. And a special thanks to our sponsors and partners, Access Technology, the National Association for Home Care and Hospice, and Core Cubed. Join us to spread the word and help choose home when care is needed.